I'm hoping everybody can hear me. Yeah, I'm going to hopefully get thumbs up. So welcome everybody to our first joint AGM for all three CCGs across the Hertfordshire and West Essex footprint. I just thought I'd just start by explaining a little bit about why we're having this joint meeting. Over the last few years, we've been coming together more and more across the three CCGs. It's very much the way and the architecture of the new Health and Care Act that is had its first reading or will have its first reading in Parliament quite soon. And we have a joint executive team that works with us across all three CCGs. So a lot of what we do is organised and thought about and devised at scale, at that level. But I also want to clarify that much of what we do and how we do it and the interaction with our populations is at a more local level, at the level of the CCG areas. And I think that one of the things that we'll find out later is how that impacts in all of you in each of your communities. We will at the end of this meeting be explaining how you can get involved and see what's happening in your local area. And I know that East and North Hertfordshire CCG are actually going to be doing that today, and the other two CCGs will be doing that in September. The other thing I'd just like to point out is a very warm welcome to Jane Halpin, who is our Joint Accountable Officer and Chief Executive Officer, our three MDs who are all with us today in the three areas, and finally all the joint exec team, some of whom you will be seeing answering questions or explaining things a little bit later on. So I'm going to hand over now to Angus, who's just going to run through the agenda and some reflections of this year, and then I'll be saying a little bit at the end before we move on to Alan. So Angus, over to you.
Great, thank you, Nicholas. Great, thank you, Nicholas. I hope everyone can hear okay. So so just a warm welcome to everyone, and I'll be talking a bit about the agenda and what we can expect to hear this morning. After this introduction from us, we'll be hearing from our Chief Executive, Dr. Halpin, describing what's been happening over the last year. Then we'll be hearing about the annual accounts for the three CCGs. There'll be a short break at about 10:25, and then an interesting time where we can have an opportunity to hear some questions from members of the public and staff, I hope. So I was asked to give just a brief reflection of this past year, and it's been very difficult. There have been significant challenges for everyone, but I think also some successes we need to be proud of. The CCGs and our partners, whether that's hospital or local authority or community services, have come together to continue caring for patients with and without COVID. And I think responding really rapidly to some of the changing clinical practice and showing the real strength of us all working together. During the pandemic and the lockdowns, GP practices have always remained open, and GPs have continued to see patients face to face where needed, but still ensuring it's been safe for our patients and our staff. So where are we now? Well, GP practices and all our health services are still facing significant challenges. We're getting almost unprecedented numbers of patients needing our help and having to continue to offer patients initial consultations and assessments by phone in general practice, even with the easing of the lockdown restrictions. On a personal note, I've never quite experienced a summer quite like this as a GP. It feels like the middle of winter, some of the respiratory viruses in children, I'm sure people have heard about on the news, for example. So our key message, I think, is please to continue to bear with us. We continue to be here for you. And I think by working together, we can provide the best services we can. Finally, the world really continues to feel very different to how it was before the pandemic, and we have to see how things progress this in coming years. So now I'd like to hand back to Dr. Small to continue the introduction, please.
One of the things that I think has been very humbling over the last year has been the dedication of all of our NHS staff and also the care staff that we work very closely with. I'd like to say a particular thank you to our patients. who literally have been through the mill over the last year to 18 months. And I think what we should be really proud of is that fantastic vaccination programme. What people won't realise is the organisation that goes behind the scenes, and a lot of that has happened both centrally at our wider CCG level, but also the dedication of our GP teams who have coordinated this, been incredibly innovative in how they've delivered it, and also working with our health and care colleagues across the system. So I think that's the first thing I'd like to say. And this year, you know, everybody has been under tremendous pressure, as Angus said, but I really feel that what we've achieved in this last year has been bringing together our district councils, our health and care partners, and I want to make a particular mention to our voluntary sector and the volunteers who have helped to deliver that vaccination programme. It is truly remarkable, and I really want to pay a special tribute to everybody in the system who have done this. A little bit now, just finally, about housekeeping before I hand over to Alan. As you will see, the microphones and cameras are automatically switched off, but you can still see the questions. You will notice that on your screen there's a Q&A option, so please do use that to ask your questions, and then we will try and answer them during that Q&A session. And then just a final thing to mention is that the whole session is being recorded, and you will be able to catch up with that if you'd like to see anything again. So without further ado, I'm, as I said, going to actually hand over to Jane, not to Alan. Sorry to confuse everybody, who's going to take us through a review of the year 2020 to 21. Thank you, Jane.
Thank you very much, Nicholas and Angus, and welcome to everyone that's been able to join us this morning. I'm going to spend about the next 15-20 minutes going through and reviewing the year, and we'll pick up and expand on some of the points that have already been made in that introduction. So if we could move to the first slide, please, Vanessa. So if I start by just giving some background and putting these three CGs and our integrated care system into a little bit more context for people. We are currently 3 clinical commissioning groups working together closely, as Nicholas has said, and the intention had been to progress to merge the 3 CCGs into one. However, we have, during the course of the year, known that different legislation was being proposed, and indeed it came into Parliament this week, and I will pick up on some of what that means for a slightly different future in a little while. We were granted integrated care system status in May of last year, just before I joined the CCGs in June. That status recognised the progress we had made to move beyond working as organisations working in parallel to actually working really closely with our partners, whether that's acute hospital trusts, providers of mental health or community services, or local government partners and the wider community. So I joined in June as holding technically 4 roles: the accountable officer or chief executive for the 3 CCGs, but also the executive lead for the newly formed or newly recognised integrated care system. One of the first things that I got on with doing was to pull a really excellent team around me to support me, and I would want to pay particular thanks and tribute to all of them. In particular, the 3 managing directors, Sian, Peter and David, who made my first year here actually possible, because doing 4 jobs at the same time is a little bit of an ask, and particularly the whole of the team in terms of actually reflecting and managing the various different things that got thrown at us through the course of the year. And I will touch on some of those as I move on in this presentation. In terms of the 3 CCG areas, between 1.5 and 1.6 million people live in Hertfordshire and West Essex, so we're quite a big population overall, as people will know in across the area. Most of that is smaller towns, not small, but we don't have big cities, big conurbations in the way that Birmingham or Manchester or whatever do, but we have a very vibrant and very community focused population right the way across our quite large geographical area. That area is served by almost 150 different general practices who have been working increasingly over this year and the previous year as part of what are called primary care networks, so groups of practices and other primary care providers who choose to operate together in a networked way to provide better support around very local communities. And when we come to vaccination, some of the real benefit of that way of working will come out. This presentation is only designed to be a real kind of whistle-stop tour, and as has been already flagged, there will be in further local meetings that will pick up some of the local detail, and indeed more detail can be found in each of the CCG annual reports which have recently been published. So if we can move to the next slide, Vanessa. So I wanted to start with just reflecting on the impact of COVID, because it really has been the defining feature of 2021. I think there's just no two ways about that. I want to start by echoing the words that Nicholas and Angus have already said about the efforts that all NHS staff and care staff and partners have put in throughout the pandemic. And that really is all partners. We've had such support from local government partners, not only in social care sectors, but also in police and fire services, in terms of coordinating and helping maintain and sustain a really prolonged emergency response. We've kept maintaining well-being of staff as one of our priorities, and one of the things that I'm personally really proud about, and our HR director, Hein Scheffer, and colleagues have been material to bringing about, has been the launch of a health and wellbeing support offer across both Hertfordshire and Essex for all health and care staff to access. I would also want to pick up and just reinforce what Nicholas has said around the contribution of the voluntary sector right from the beginning, in terms of supporting with food parcels and delivery of medicines to those who were shielding, through to marshalling at vaccine centres, often in very inclement weather through the winter, and all sorts of things too broad to articulate in this short presentation. We would not have endured this year so effectively and so well without the support from so many people who've given generously of their time. The pandemic has changed how the NHS works quite fundamentally. I think the most obvious way people will have experienced this is how technology has changed the way in which health services have had to operate or been able to support the necessary change over this last year. And in some ways, it's not been a bad thing, and it's been a catch up. Most of us are now very used to doing all of our banking online, much of our, well, when we were able to travel online, shopping online. Clearly this year has come into its fore. So to a certain extent, this has been partly the NHS catching up with a broader societal change. When the pandemic first really hit, the CCGs rapidly deployed technological solutions that enabled care to continue in a safe way, And bearing in mind, right back at the beginning of that first sort of peak in the spring of 2020, there was such limited understanding of what we were really dealing with, that the confusion and the concern was probably at its highest. So examples of what was done were thousands of laptops and cameras being made available very, very quickly to those 148 general practices. We set up arrangements to ensure that information could be easily shared, but safely and accurately shared to allow practices to work together more efficiently. Electronic prescriptions, which many practices had already been supporting, effectively became the norm everywhere. And we had some really innovative practice. So we were at the forefront of developing what we refer to as virtual hospital, which is a means of being able to take monitoring equipment out to people's homes and enable people who did not at that stage need hospital care to be safely monitored, to check that they were continuing to be sufficiently well to stay at home, or indeed if they were deteriorating, to notice that and be able to bring them in a measured and respectful fashion. So where we've ended up in that last year were that around about 50% of general practice appointments are over the phone or online in some way, with the remaining 50% being face-to-face in the surgery. And that is clearly a shift from where we were pre-pandemic, where it would probably on average have been more like 25% technologically supported, 75% non-technologically supported. We have, as well as using tech, seen much closer cooperation, which I've already started to highlight, between a whole range of different organisations. And that, again, I think, and we all think in the three CCGs, is actually a good outcome of a very difficult year, that it's really focused what we can do in partnership better to make sure that patients can get the care that they need in the place that is safe for them. And our primary care networks have been particularly key to accelerating this transition in terms of how they came together to support patients in respiratory hubs, for example, in the earliest days, and with vaccination as we move through. So Vanessa, if we could have the next slide, please. So just expanding a little bit more on primary care, as Angus has said, primary care has remained open throughout the pandemic. However, the model of care has had to shift to maintain safety for patients and safety for staff. General practices, GPs, nurses, and all of the staff have worked tirelessly on both COVID support and non-COVID care, as well as vaccinations, which I'll pick up in a moment. One of the things that was developed very early on were what we referred to as hot and cold hubs. So effectively streaming of patients to ensure that those individuals with symptoms that might suggest COVID were sent to a different facility from people who needed more routine standard care, perhaps for long-term conditions, to protect people from the risk of COVID transmission. And that was set up really, really quickly and worked really well, particularly through the first wave when we were still struggling to understand the full implications of what we were dealing with. And certainly had a material impact on reducing transmission between patients and staff. In general, the system for accessing primary care switched to something we refer to as total triage. In other words, there needs to be some form of conversation first to identify what the best route for the next step should be. But face-to-face appointments have continued throughout, and patients have been able to see their GP or, for example, a GP in a hot hub where that was needed. It just required a different way of accessing than previous to COVID, where you would simply have rung your own GP and the receptionist would have booked you an appointment. Primary care are seeing more patients now than they did pre-pandemic. The overall number of appointments that we're seeing in primary care is something like 15 to 20% higher than it was before we went into into this pandemic, but we are managing that demand in different ways. As I've said, there's a higher proportion going through online and telephone routes, but the overall volume of care being provided is higher, and I think it's important that I stress that. In terms of how hospital care responded, initially in response to the original overwhelming sort of peak and demand that came in the early spring, a lot of work was done to reconfigure internally, to expand the emergency departments wherever possible, and introduce pathways that again streamed patients, separating at the earliest opportunity patients with temperatures or COVID symptoms into separate areas, and keeping the non-COVID related patients safe from cross-infection. This also included shifting activity between different hospital sites. So, for example, the urgent care centre at the new QE2 in Welwyn Garden City was used more and accepted all of the minor cases that might otherwise have gone to Lister, to free up Lister to focus on COVID and more seriously ill patients. The hospitals increased their number of critical care beds quite markedly, and both particularly West Herts Trust and Princess Alexandra Trust probably were across our footprint the two that were most impacted by higher levels of COVID patients, and at their peak, around 2/3 of all inpatient beds in West Herts Hospitals Trust were occupied by patients with COVID. This meant that for all of our trusts there had to be a pause in non-urgent surgery, so not surgery for conditions that may be life-threatening, but surgery that might be, for example, for a joint replacement or a hernia repair. And this was needed partly to create the space to increase the number of critical care beds. ITUs typically are not very big, so that expansion was achieved by using different parts of the hospital estate, including theatres and anaesthetic rooms, but it also allowed our acute trusts to redeploy staff to where they were most needed to support seriously or critically ill patients. CCGs also supported the acute sector with staff who have clinical backgrounds volunteering to go back and operate at the front line, supporting hospitals and NHS 111. Mental health and community services were also impacted, but also continued to deliver care, again often through remote ways of working. They continue to support people who are particularly vulnerable, and in both inpatient and outpatient settings, and again adopted new ways of working, including the remote monitoring and virtual wards approach, as I previously mentioned. CCGs helped in a number of ways, supporting general practices and helping them prioritise which services they most needed to continue, and how that could be achieved. We helped with coordinating, interpreting and disseminating huge amounts of new and changing guidance around every aspect of this, including personal protective equipment, PPE, and supporting GP practices and care homes in accessing and using PPE safely. And I would particularly pay tribute to again the work that was done both from the CCGs but also with county council colleagues to actively mobilise support to care homes right the way across Hertfordshire and West Essex. And lastly, I think the role of providing information to the public around access to health services and other aspects through the pandemic has been key. So Vanessa, if we could move on to vaccinations. Having been somewhat downbeat about COVID, I think the vaccination programme is absolutely something of which we are all incredibly proud. As Nicholas said, there are massively complex logistics that underpin this. This was a programme rolled out from scratch with very little planning time. We had around about 4 weeks planning in the late autumn of last year, and then we went live in early December with the very first vaccinations in Hertfordshire, and then rapidly rolled out, so that at the peak of our vaccination delivery we were operating from around 40 sites. We have also tried beyond physical locations to ensure we reach everybody, including homeless populations, traveller communities. We've done outreach sessions. We have run communities in particular ethnic minority settings. We've provided pop-ups in supermarket car parks. We've used vaccination buses. It's been a hugely inclusive programme, and it continues. And I want to stress that it continues. We're currently vaccinating more younger age groups, and really keen that they access vaccine just as much as older ones have. The vaccination programme is completely inclusive and non-judgmental, and is open to anybody. We don't need to see ID, we don't need to know which practice you're registered with, or indeed if you're registered with any practice. We've made decisions to really focus on some of the most vulnerable groups. So for another example being people with a learning disability, we could see from the audit work done in the first peak that people with a learning disability were disproportionately at risk of severe COVID infection and death, and we therefore put some really focused emphasis on reaching out to everybody that we knew to have a learning disability right at the start of 2021 when vaccines were available, and had really considerable success in that. Very, very quickly reached over 88% of that population. We also provided support for practices in terms of project management, pharmaceutical oversight, to practices who are maintaining services to their own patients, and helped the PCNs who came forward to offer vaccination, again to get up and running as fast as possible. And those primary care networks have been a hugely important part of delivery of local vaccination. Roughly 75% of all of our vaccines so far have been delivered through that route, and that has been a real marker of how flexible and innovative primary care locally have been in coming up with models that worked for the communities that they understood and were close to. And our very strong performance in vaccine uptake is a definite marker of success of that approach. We are, however, also extremely grateful to Herts Community Trust, who've been our main vaccine centre provider, and also community pharmacies who volunteered to offer vaccination as soon as that was possible, slightly later on in the programme. I think I would also want to flag that the other logistic challenge in all of this has probably been the fact that guidance kept changing, or not kept changing, but evolved from the Joint Committee on Vaccinations and Immunisation, or JCVI. So, for example, we started with a 3-week gap between vaccinations that was rapidly pushed out to a 12-week gap between vaccinations. We had to accommodate to the changes to the understanding of the risk profile of the AstraZeneca vaccine and change the age range for that. And more recently, we've had the change from the 12-week gap between vaccinations now come down to an 8-week gap. We've had periods where vaccine supply has been quite challenging, and we have had periods where there have been short notice changes to expected deliveries, which have again required great sort of flexibility and tolerance from particularly our PCNs and Herts Community Trust. I'd just like to restate again my thanks to the thousands of volunteers who are particularly marshalling in car parks, welcoming people, reassuring them, and their support has been absolutely invaluable in making this possible. And what has been possible is that as of the end of last week, we know that over 1 million people across Hertfordshire and West Essex have had a first dose. That's approximately 77% of the adult population. 725,000 have had both doses. That's around about 56% of the adult population. We're now starting to plan the booster programme in the autumn, about which we don't have much detail yet, but I'm sure we will shortly, and we'll be communicating with you about that. So Vanessa, if we can move on, please. So clearly, there have been significant impacts on service provision through this last year, 15 months. And I just wanted to briefly touch on some of the work that's currently going on to address that. We have capacity continues to be less than it would otherwise have been, because we need to continue good infection control measures. And we are currently working closely with Public Health England and other parts of the NHS to ensure that when we get to July 19th, there are measures that remain in place in health settings that are appropriate for those settings, mindful that the footfall in healthcare settings is disproportionately skewed towards elderly, vulnerable and at-risk patients. And it's not the same as the hospitality sector. So we don't envisage quite the same complete relaxation being in any way appropriate, but we are working through what is possible to see how we might be able to get a little bit more capacity, a little bit more ability to push people through whilst maintaining perfectly reasonable safety levels. In terms of some of the mechanisms that we're already using to address that capacity, we've been using NHS 111. From December, it's been possible to directly book patients in emergency departments into appointments, patients into appointments in emergency departments in a time slot, which means that the numbers gathering in waiting rooms will be smaller, and also means for the patients that they will be waiting for a shorter time. We've been developing and offering more same-day emergency and ambulatory pathways. So if people don't need to be in hospital, if we can provide their care safely and effectively in other ways, we do so. We know that the vast majority of people would much rather not be in hospital unless there really is a need to be. We've kept a really clear focus on cancer care and on diagnostics. We have continued to encourage people that may have symptoms of cancer to come forwards despite the pandemic, but we do know that there has been an impact on people perhaps presenting later than they might otherwise have done. But we have very good statistics in terms of the extent to which our cancer services and diagnostic services have been maintained and are already catching up rapidly on any backlogs. For general waiting lists, we have undertaken a process of prioritising these in clinical order. So rather than simply taking the patient waiting longest, we have a process that ensures that if there is a patient at higher risk, whose condition may deteriorate or whose health may be more impaired by waiting, that they come forward sooner. But equally, we have very good communications, we think, going on with those who are on waiting lists to help them have some idea of when they may well be seen, particularly those at higher clinical priority. We've been expanding diagnostics care, theatre time, using the independent sector, who have been materially part of how we've been able to keep going and not have as big a backlog as might otherwise have been the case. And we are increasingly turning our thoughts towards support post-COVID for those patients who have been infected in terms of assessment for long COVID and signposting towards support and treatment. In terms of our current challenges, if we move on to that slide, Vanessa. Thank you. I think there's a number of quite complex strands to draw out here, so I will spend a couple of minutes on this slide before moving ahead. COVID has really made inequalities in the population and health inequalities much more stark and much more obvious. And that's been at so many different levels. It was recognised in the first wave that people from ethnic minority backgrounds were at higher risk of both contracting COVID and of being seriously ill, for example. And within the NHS, we risk assessed staff to identify those at particular risk and help redeploy them to areas where they might be able to work more safely. We have continued and are continuing to work really closely with local government partners, both at county council and district council level, around those wider inequalities that COVID has made more evident. So as one small example, the move that schools had to make towards online only teaching for considerable periods of the year worked differentially for a whole range of different reasons, but what it did highlight was that there were significant numbers of young people learning in our schools that did not have access to any form of laptop or tablet that allowed them to continue to participate in the curriculum in a meaningful way, or indeed that they didn't have Wi-Fi that would support access to learning. So that's just one small example of some of the non-immediately health side of inequalities. And we're now working, as I said, with local government and other partners to try and understand the breadth of this and put plans in place to address it more effectively in future. Specifically with a health lens, we've been piloting programs like one called Making Every Contact Counts, so supporting people to access additional health services to meet their wider needs when we've been coming into contact with them through COVID or COVID vaccination. And this has been prioritising those people who are particularly vulnerable, such as the homeless, people in refuges, or adults who we've identified as not registered with the GP, and helping them access registration for future support and care. We're, as I've said, increasing capacity to try and catch up with backlogs, but we're having to manage that against an NHS and care sector workforce which have been working additional hours for now a very long time. So that is a balancing act between the absolute desire to provide as much capacity for patients as possible, but the realisation that if we push staff too far and too hard, actually it's going to be counterproductive. Again, we're using independent sector support with this. Inpatient visiting is gradually being reintroduced and restored, but we anticipate that we will still need to be very cautious in some smaller areas. So, for example, smaller practices with the GP waiting rooms are going to present an ongoing challenge for all of us, but work is taking place on that. As I said earlier, I think aspects of virtual care are definitely here to stay, and many of them are quite positive. The work that is taking place, for example, on patient-initiated follow-up, which our jargon calls PIFU, but is essentially looking at outpatient services and saying how many patients coming regularly in and out of outpatients actually aren't deriving much benefit from seeing a consultant or a healthcare professional on a fixed time interval, like 3 months or 6 months, but actually might get much better care and have much better control of their illness if they were able to identify when they needed outpatient support, virtually or in person, and arrange that in a more fluid way. So that's one example of that taking off. We've recognised throughout that there has been a very significant mental health need as well as physical health need, and we have commissioned local work to look at what we think the increased demand, not just now, but looking ahead into the short and medium term future will be. In the short term, we're seeing higher rates of attendance in all settings, general practice, emergency departments and mental health services of patients with acute mental health needs. And those needs are often more complex and more acute than we would have seen prior to the pandemic. We know that there will be, we're already seeing significant demand for support for eating disorders and child and adolescent mental health services. And we're also anticipating seeing increased demand in younger children as well, in part the children who have not been able to socialise in the way that they might normally have done so, and expecting to see greater anxiety and low level sort of disruption that will ensue. So plans being made to deal with that as well. I think the main point really is that we're seeing extra activity at the moment everywhere. Where, as I think Angus said, it's already like winter. It's already like winter in all of our services. So whatever we sort of see sometimes in the press about, you know, it's EDs, emergency departments are particularly busy. Well, they are, but they're the more visible part of being busy. Our mental health, our community services, our general practice services are all very busy, but very, very committed to giving patients the support they need as best we're able to do. We have been also working, despite this, on improving the NHS estate, both on small scale examples or smaller scale examples. So Dolphin House Surgery in Ware have moved into their new building on the site of the old fire station. Latimer Surgery in London Coney is moving into its new premises later this month. And Saffron Walden Community Hospital has been refurbished, which means that Crocus Practice has been able to move in, having outgrown its previous premises. And looking to the future, we're also looking and have been working intensively on plans for very major estates redevelopment at both West Herts Hospitals Trust and Princess Alexandra Hospitals Trust. Finally, looking ahead for the coming year, we celebrated the NHS's 73rd birthday on Monday with a very unusual but very effective online tea party, which involved members of staff learning how to make sponge cakes using a minimum number of ingredients and a microwave, further suggesting that innovation is definitely here to stay, although I have to say the results were mixed from what I could see on the pictures. But I think that's, although that's a bit light-hearted, it's part of how we continue to try and support the well-being of staff. It's not just about the sort of the formal things we do, the employee assistance type programs that I referenced earlier on, but also the actions that we're taking on recruitment and retention and on job redesign and workforce planning. We continue to support COVID care and COVID vaccination. We are now in the third peak of this pandemic. We are seeing increased numbers of cases being reported, and that is translating into increased numbers of patients in hospital. Right the way across the east of England, all of the hospitals currently have COVID patients in them, which was not the case if we look back about 4 weeks. The numbers are smaller than they were in the second peak, but there are still numbers of patients being admitted, significantly ill, needing very intensive levels of support, and we are still continuing to see deaths. So it's important to remind ourselves that we are not out of this yet, and we won't be for quite a considerable amount of time. What we're doing is moving into a phase of how we can live best with the current reality, as opposed to the first wave of how do we actually try and keep people safe and try and develop vaccination. So I think this will be a year of further change and further evolution, but as hopefully I've highlighted in the last few slides, there are some real positives as well as some challenges in all of that. We continue to try and transform the service delivery, including accelerating the restoration of elective and cancer care, managing the increased demand on mental health services, managing the expansion of community services to support patients outside of hospital. We are continuing to expand primary care capacity to improve access, address local health inequalities and help improve local health outcomes. and that is through a whole range of approaches, particularly including additional roles such as social prescribers, paramedics, and other support workers in primary care. And I'm particularly grateful for the support of Avni Shah and Lynn Dalton, two of my colleagues who lead that work, working with primary care and PCNs. We're continuing to transform urgent and emergency care, preventing inappropriate admission at emergency departments wherever possible, and streamlining pathways wherever we can. Some of that is through the work directly with emergency departments, but some of that is also through work on patients whose care could be better provided without access to emergency departments in the main. So things like our frailty programme, which Sian Elton has helped lead alongside the urgent care programme that David Evans has been leading. And we're working collaboratively across the system to deliver on these priorities. As we've touched on before, we expect to roll out into phase 3 vaccinations with COVID in the autumn, and I'm particularly grateful to support from Peter Whiteman and Avni Shah, who at various times have led this programme over the course of the year and handled the complex and frustrating logistics with great diplomacy and patience. In terms of the last area just to focus on, which I touched on right at the beginning, we expect to become what's called now a statutory ICS, so an integrated care system that incorporates the functions and responsibilities of the 3 existing CCGs, as well as taking on additional functions from NHS England, subject to the legislation that was tabled this week, progressing as government anticipate. That will take place or go live from April 2022. So there is an awful lot of work that we will be doing on that over the coming months, but also reaching out to partners and the public about how they can help shape and improve things for the future. So I appreciate that's been a slightly long presentation, but hopefully it's been of some interest, and I'm grateful now to hand over to Alan Pond to take us through the 2021 accounts. Thank you.
I think I'm now live. Good morning, everybody, and what a fantastic morning it is after a glorious night before. I don't think I need to say anything more than that, but the other good news is that Jane's taken most of my time. I think I'm now left with about 7 minutes, so that's good news for you all as well. My name's Alan Pond. I'm the Chief Finance Officer for the 3 CCGs, and I'm going to take you through the 2021 financial position. If you can move on the slide, please. So this is just to remind you of the statutory duties that CCGs have. So the first one is around keeping within budget. That's both capital budgets, so for things like buying equipment and buildings and so on, but also within what are called revenue budgets. So that's paying for staff and other smaller items of expenditure. We also have to keep our spending within a running cost allowance. So that's how much we spend on our own organisations. And that value has been reducing in real terms year after year. So we have to be more efficient in the way that we commission services, and we spend less on running our own organisations. Then we have to make sure we don't spend any more cash than we're allocated. We have to achieve value for money. We have to produce annual accounts and reports and hold an AGM. That's obviously part of today. And then we have to keep appropriate accounting records. So we can do all of those other things. If you move on, please. Now, 2021 was a very strange year. I mean, Jane's been through a lot of the challenges that we're facing, the NHS and CCGs, and the financial regime was changed to accommodate those challenges and to to make the system less bureaucratic, to enable us to focus our efforts on providing good patient care, effective care, and making sure the NHS responded as best it could to the pandemic. So some of those changes, and the year was one of two halves. So there was the first 6 months, which was known as H1, and the second 6 months, unsurprisingly, known as H2. So for H1, we effectively ended up with a non-cash limited system. So basically, NHS England were telling us, and they'd negotiated with Treasury, that money was not the object. It should not be a barrier to responding to the pandemic, and that whilst we still needed to achieve good value for money and look after the taxpayer's pound, that should not get in the way of the response that the NHS put up. That changed back to a cash limited system in the second 6 months of the year, with the budgets for CCGs in effect being calculated by NHS England and being given to us. And I'll come on to that a little bit more in a minute. Contracting and commissioning was stood down. So that's reduced the bureaucracy. We had mandated block payments to be made to providers. And on the other side, NHS England calculated what they thought the providers would need to be spending and provided additional top-ups. In the first 6 months of the year, because it was a non-cash limited system, in effect, whatever the NHS spent, it was reimbursed. There was some degree of control on, the professionalism of people in the NHS about achieving value for money. It didn't go away. It just meant that the money wasn't a barrier to doing the right things. The independent sector, the contracts were ceased, and they were contracted directly by NHS England. For non-NHS providers, there was much more of a light touch to contract management, and we were encouraged to support providers to maintain sustainability, because these providers will be needed at the end of the pandemic. So we needed to make sure as much as possible that providers were still there at the end. For primary care, income was protected at 1920 levels. COVID expenditure was reimbursed, and then there was some additional COVID expansion funding that came in the second half of the year. The last one around efficiencies, there was no formal efficiency program that was required. In the first half, non-cash limited, as I've said before. In the second half, it was, you have to live within the financial envelope you've been given, but no formal requirements around delivering cash releasing savings. So if you move on to the next slide, please. So this is where I would normally show the scales of what the pressures were on demand and the inflation and cost pressures that we were facing, and what the funding growth was, and therefore what the efficiency requirements were, and what the cash release and savings would need to be for us to balance the books. And as I've just said, that kind of was pretty much stood down in 2021. And so you might think, well, money makes the world go around, and money changes everything. So if we were told we just got as much money as we want, why would we have a problem? And the reality is that whilst everybody thinks money is the scarce resource, often it's not. You give me a bag full of money, but if the staff aren't out there, then I can't secure the capacity to deliver the services. So the challenges for the NHS in 2021 were less about balancing the books and much more about using the scarce resources, our people, and sometimes our premises, in the most effective way to get not best value for money as much as best outcome for our population. And Jane's been through a lot about the things that we were doing to achieve that. And the challenge was much more then about how creative can we be in changing the way services are delivered, and in bringing in new technologies to support that patient care. Can we move on, please? So the financial context for CCGs in 2021 And this is more really associated with the second half of the year when we went back to it being cash limited. And one of the problems always is that if you calculate things at a macro level, there are always local micro level circumstances that don't quite fit. So although the funding in theory was sufficient to deliver everything, and in theory there were no cash release and savings, we still, as a system across the CCGs and our provider trusts, we still had to work together to make sure collectively we produced value for money and we delivered financial balance. Some of the good things for the CCGs, so expenditure volatility was reduced because we had the block payments. That also meant we could redirect most of our efforts onto what made a real difference to what we did in terms of the outside world, and less focus on internal transactions. So that's again saving in bureaucracy. The CCGs were challenged to reduce the time it took to discharge people from hospital. So working with the local authorities, hospital discharge programme was a funding stream that enabled us to make quick decisions, joint decisions that best met the needs of patients without arguing about who was going to pay for it, frankly. There's a significant change in the demand profile. So less elective work being undertaken, a lot more urgent emergency care being geared up for, and a significant impact on critical care. So the scale of the changes that needed to be made, including new technologies, that was a challenge, less so the money. And funds were allocated to integrated care systems, so not legal entities, but a collaboration of the system, for us to use in the most flexible way that we could. So again, it was encouraging joint working across organisations and a system approach rather than individual organisation approach. If we can move on, please. So how do we do on the financial duties? I mean, you see a lot of green, so a sea of green apart from a few ambers, and the ambers are where the financial duty wasn't applicable in the year. So there were no reserve matters and we didn't have any capital spending. So for those ones, in effect, we achieved them because we received nothing, we spent nothing. The only other one I'd want to point to, and you kind of think, why would I point to this? So it's the third one from the bottom. So to produce annual accounts and an annual report. So with the year end of 31st of March and having to produce the accounts by the 27th of April, it's 27 days, or put it another way, 27 working days. And so I'd like to thank the three teams that I have within the three CCGs for the hard work, the dedication and the professionalism that they showed yet again to produce the accounts, to get us through the audit and get us to a position where we've achieved all of our targets and we've done it in the time frame that's required. And achieving the targets is more than just the finance teams, it's how the whole organisation works. So again, thanks to the organisations for the way that we all pull together and work together. Can we move on, please? So looking forward then to 21-22, the regime is similar to the regime that we had at the second half of 2021. There are a few changes. So one is that independent sector commissioning comes back to CCGs. The second one is the elective recovery fund, which in effect it's money to incentivise more elective activity. So whilst we have a cash limited budget again for 21-22, that doesn't apply to elective care. So the more elective work we do, the more we get paid for it as a system. And part of the elective recovery fund and access to it is making sure that we're targeting the right patients. So those that have the highest need, have been the longest waiting, and ensuring we reduce inequalities. We also have system development funding, which provides targeted support Most of that's going into mental health, primary care and community services. Urgent emergency activity, the expectation is that it will recover back to the 1920 levels. Well, theoretically, less COVID patients, although we'll see what happens because case numbers are going up, or, albeit at the moment not in hospital. The other good thing is we don't expect to return to the previous contractual and payment regime. So I think having had a year where we've been encouraged to collaborate and work together, that's something I would wish and would want to see continuing. Move on to the next slide, please. So that really just sets out the comments I've made before about what the changes are. So in the interest of time, I won't go over that again. So next slide, please. So this is the slide that I would normally show you going into 21-22. And yes, it's going to exist in the second half of the year. We do expect to have to deliver efficiency savings. We don't know how much yet. The NHS England is still negotiating with Treasury, but the mood music says that the money will get a bit tighter, and therefore we haven't taken our eye off the ball of value for money and getting value for the taxpayer pound. It will become more important in the second half of the year, but we've known this was coming, so it's not a surprise, and we're working well together across the system with our providers to make sure that whatever the challenges are in that second half of the year, that we can rise to them. That's what I wanted to say, and I think I'm a few minutes overdue, and thank you very much, and good luck for Sunday.
So welcome back from that short break. Hope people have found the presentations helpful. We have a fair number of questions which I'm going to try and sort of act as coordinator for, and they cover a range of topics. I think probably the biggest single area of topics is around primary care services access. So rather than take the questions one at a time, I'm going to sort of take all of them and suggest that between the three CCG chairs, but also Avni and Lynn from our primary care team, that probably be sensible to cover the responses. So the first one that I've noted is from someone actually saying that the phone and online appointments, they would be very grateful if they continue, as they found it much easier to get an appointment than they have in the past. And it particularly around the other aspects around primary care. I think in opposition to that experience is one saying so many of my clients and myself still struggle significantly to even get the receptionist on the phone. Waiting times can be over 40 minutes. We can be cut off. Then there are no appointments, and so on. So if I start maybe with that, because that feels like sort of effectively the two ends of the spectrum around primary care. So maybe Nicholas, if I come to you first, if that's okay.
Yeah, that's absolutely fine. So I think the first thing I want to say is that we do accept in general practice that there have been times for individuals who have found it difficult to access the right service at the right time, and we all are very sorry if that's the case. But we have in general practice had to adapt to an unprecedented change. Behind the scenes, we've had to adapt to a completely new way of working for many of our GPs. We've seen an incredible rise in the number of GP contacts, and also, may I say, the complexity of the problems. We've seen a very large rise in mental health demand at all times, and I just want to make this absolutely clear: GP services are open. You know, we are seeing face-to-face. In fact, in many practices, that's beyond 60 to 70% of activity at the moment. It's an enormous challenge to do that, though, because we want to keep the best of the on the day of the telephone and video consultations that we were using at the very beginning of the pandemic. And let's not also forget that you also have the ability, and it's slightly different in each practice, to have online advice and consultations. But the effect of all of this has been that we've had, if you like, an enormous number of different ways that our patients can interact with us, and that does put pressure sometimes on our telephone systems. Now, in fairness, all of our CCGs have tried to invest and support the practices in improving telephone access, but there are times when it will never be enough, and we're really sorry about that. But we have a limited workforce, we have a limited number of receptionists. So as we open up more, and providing that it's done in a way which is compatible with all the health and safety aspects, because we need to protect our patients, you know, then I think that all of you will see a further increase in those face-to-face appointments available. But at the same time, if people want, and they do want, the other sorts of services, we're going to find it, you know, there's only so much that we can do within the resources and the manpower that we've got. I think the other thing I'd just like to say is that in general practice, we are, you know, hearing the most incredible stories, the most moving stories, and we really do understand that for some of our population, this has been an incredibly horrible, awful time, and to do that and to take some of that time, it takes quite a lot of time in a GP appointment. So if I just very quickly, one of my surgeries, there are often people that need half an hour or more to actually go through all the number of appointments, and sometimes we will have to say, can you actually ring back for some of the other things that maybe don't need immediate care? We're absolutely open for potential cancer diagnosis, for serious mental health issues, and for people with disabilities. We have also been working behind the scenes to increase the availability and accessibility for patients. We know it's not perfect, but we're working on it. I don't know if Prague or Angus would now like to add to what I've said. I'm sure you'll have other things that I've completely forgotten.
Yes, thank you. So there are, I think there are some benefits. Oh, Vanessa, am I on? Yeah, thank you. Sorry. Yeah, so there have been some benefits from moving to this sort of online and digital way of working. For example, some of the some young families with children might find it very difficult to walk down to the surgery and see me in person. Actually, quite appreciative of having an online consultation over the video link. There are, of course, patients I'm concerned about who are more, as we describe it, as digitally excluded, and people who might not have such familiarity or access to this technology. But I do know that we have funded and worked with the voluntary sector some support and training and provision of equipment to try and help those groups. So it is a very different world that we're in at the moment. There are advantages and disadvantages, but I think we are still developing and changing how our kind of long-term approach is. A final point, I just wanted to reflect that it's a different way of triaging has, I think, helped some patients. So, for example, if I have a patient who has a very complicated case which we need to discuss and assess, there is some flexibility. I can bring them in, for example, very last patient of the day, and then I've got plenty of time. I can spend 45 minutes with them. I might be a bit late getting home, but at least I could address some of their issues in a much better way than being confined to a rigid 10-minute appointment. But that's just a couple of personal reflections.
Yes, can I just, am I on? Yeah, so I think Nicholas and Angus have covered most of it. Just to say, to reinforce, the general practice is open. Unfortunately, because of COVID, our capacity in terms of seeing patients face to face is also reduced because of the amount of time now that we have to spend cleaning up after seeing each patient as well. So not only has our workforce shrunk during this period, we've also shrunk in terms of the capacity, in terms of how we're seeing patients. So, but the bottom line is we're still open for business. We've changed the way we work, and I think, to be honest, that's going to continue because COVID is here with us and is going to stay. We have to protect our workforce. We have to protect other patients that come into the surgeries. So nothing further to add. Thanks.
Thank you. So, hello everybody. My name is Avnisha, Director of Primary Care. So just to add on a few things, like Nicholas, Angus and Prague have just said, we've got to learn to live with COVID now, and there are masses of changes that we've already made and good progress has been made in primary care, but how do we build on it? Telephone access is absolutely one of those areas that we are currently looking at and working across Hertfordshire and West Essex, working with practices to say which practices would benefit in terms of the infrastructure change and how we can support them. This work is actually aligned to some of the work that's done nationally with NHS England, looking at a specification that will benefit not just for now, but what it means for the future, because we do understand that the whole general practice model has changed fundamentally and is here to stay. In addition to that, the workforce has changed as well with that. So we mentioned about the additional roles as well, but as Prague said, we need more of the workforce. We've got to actually invest in terms of how do we create new opportunities and reset to actually create opportunities whereby we have portfolio roles, giving people part-time roles, but increasing the workforce footfall overall as well. So there are a number of plans and programs in place working across with our partners to see if there is potential for rotational roles or to actually develop roles from further. COVID has shown that we have an unregistered workforce currently working with us throughout, whether that's in community trust or whether that's in primary care. And what we're looking at is an opportunity to actually bring that workforce back into the NHS to help us in the future. So what you will see over the coming year is how we engage with yourselves as partners, patients, public, to actually look at it in terms of how does the GP model work, operate differently, and how do we actually engage with yourselves to see how we change that perspective as well in the future. Hope that helps.
So thank you. Hopefully that helps give some background to expanding on that area. I want to move us on now to a different aspect that's come up, which is health inequalities. And there was a question that came in. If I just go back and try and find it, yes. There's two. There's a question that says currently there are some short-term plans being rolled out. What are some of the longer-term plans as things will only potentially get worse? And then one from Veronica saying needing to take account of patients and those from seldom heard groups such as carers, and how can we better support carers? So I'm going to ask Peter to respond to that in 1 second, but just one point on carers is that through the vaccination programme we've actually had a much better identification of carers than we ever have before, so we're in a better position to step up on that. But Peter, if you could perhaps give a perspective on the health inequalities issue.
Yes, hello everybody. My name is Peter Whiteman. I'm Managing Director, West Essex CCG. Yes, I think in terms of health inequalities, 2 or 3 comments I'd like to make. I think first of all, in terms of the workforce, a key part of primary care networks is introducing more and more social prescribing capacity. So through primary care networks, some of the extra roles that colleagues have been describing include care coordinators. So when people approach the practice for something that might relate to health benefits and accessing financial support for their debt, or it could be to do with social issues or softer issues relating to the voluntary sector, that workforce is able to connect people to the right support sector, which could be voluntary or statutory, and that's been really helpful with practices. And primary care networks are critical here in terms of building those GP relationships with the local voluntary services and the things that they can offer. So I think there's a extra capacity for connecting people in those areas, and we're working closely with the voluntary sector to think about all of the extra demands on their time, and an important framework was brought to the joint 3CCG board last meeting, setting out how we want to work with the voluntary sector to continue work to develop that further. I think the second area I want to touch on is data. We've been a national pilot for population health management data, which is taking all kinds of information that is collected on activity levels and deprivation levels, and that's helping at a practice level and a population level think about how can we target our interventions. And I know in Uttlesford that Angus has been working on that, working closely to use that data. So you could say, OK, with our diabetic patients, we'll know which of the diabetic patients who are interacting less with the health service, and using some of that data can help us to pinpoint some of the actions that we need to take with our voluntary sector colleagues and Diabetes UK to think about how we can support patients in a different way, recognising that some of that is digital, but also some of that is face-to-face and in different ways, recognising that, as we all know, health inequalities and digital is a risk for us going forward. And then a final comment from me, the vaccination programme, I recognise is short term, but I think it's pointing to lots of ways that we can work differently. Because of the data that we have, we know exactly what the patterns of vaccination uptake is at a ward level, and we can see connections to particular groups. It could be linked to deprivation, it could be linked to particular ethnic groups. and we've been working with mosques in Watford and starting to do that in Grange Hill, in Chigwell area, to think about how can we improve people's uptake for communities that might be more cautious about wanting to uptake on the vaccine. And we're bringing mobile vaccine services to Waltham Abbey and other areas to try and make this vaccination programme as accessible as possible. But we're using data to help us to take that next step. And we have vaccine trackers who are calling people to say, well, who haven't taken the vaccine up so far, to think, well, okay, how can we help you, to talk through any concerns you might have and connect you to whatever might be your most suitable service. That's just a few examples, but absolutely, I think as a health service, we've been really clear that health inequalities has probably been increased as a result of the impact of COVID, and so it's more and more upon us to do something positive and proactive to respond to the differences that the community are experiencing.
Thank you, Peter. Conscious we've only got a few minutes left. We'll try and get through as many questions as we can, but if not, we will find we will make written answers available and get them out to people. So I thought it might be helpful next to go to a question that said integration is very complex. What can be done to facilitate efficient communication between GPs, community nursing services and staff attending to patients in their home? And I wondered perhaps if Sian, you would take that since you lead our frailty work overall.
Thanks, Jane, more than happy to, and I'll try and be quick. So 2 aspects really, predominantly through the kind of digital integration programme. So we have done a lot of work over the last couple of years and pre-COVID in terms of making sure that our community nursing teams can access the GP record, so there isn't duplication of documentation of information, which poses its own risks. But more recently, quite a number of programmes to ensure that remote monitoring is available in patients' own homes, which Jane also touched on earlier. And we've been doing that work jointly with Hertfordshire County Council as a pilot in the first instance, and looking to roll that out more formally so that more patients can be safely managed in their own homes. I think the other aspect to draw into this bit of the discussion, and again Jane touched on earlier, around the kind of new roles that we've introduced into primary care and to support people in communities. So those are the social prescribers, the care coordinators and navigators, and they are really helping to ensure those people that possibly may have been excluded from accessing digital or benefiting from digital technology are now included. So some of that is around the care navigators and coordinators in particular, helping to support people with beginning to use and understand how technology can support them in terms of staying at home and breaking down some of those barriers and increasing people's confidence in terms of embracing technology. So I'll leave it there if that's okay, and more than happy to expand on that question if necessary at a future date. Thank you.
So, thank you, Sian. Alan, there was a particular question about hospital discharge programme funding ending on the 30th of September that was specifically directed towards you. So I wondered if you were able to say anything on that one.
Am I live now? Sorry. Okay, sorry. Yes, so the hospital discharge programme is actually a funding stream that was in place for the whole of 2021, and for the first half of 21-22. It's also been confirmed. And basically what this meant was that the NHS, working with its local authorities, could reclaim from NHS England for the costs of care provided to patients discharged from hospital, also prevention of admissions, So the idea being it would reduce the number of people in hospital and reduce the delays that there have previously been when it comes to assessments being done. Is it health? Is it social care? So that program was really about making sure people were in the right place as soon as they could be, and to stop the arguments about who was going to fund it. So if that does cease on the 30th of September, then the risk is we'll go back to how we were. But none of us want to do that. So we're already looking at what services do we need to commission between us and the local authorities to make sure we can continue to move people at the right time to the right place, and not to be arguing between ourselves as to who's paying for it. So we will take the best of what we've learned from having the hospital discharge programme and continue with it regardless of whether the money's going to continue or not.
So I think we'll wrap up our Q&As at this point, because we're right up against the clock, and hand over to Prague to close for us.
Thank you, Jane. Unfortunately, we had to go into extra time. Lucky we didn't needed to go into penalties. Couldn't resist that one, Alan. Thank you everyone for joining and taking part in our AGM today. If there are any questions still not answered, or you want to consider after this, please email us, and we will get the appropriate response to you. The recordings will be available on the Healthier Future website in the coming days. East and North Herts CCG will be holding its local review of the year after this meeting, and it will start sharply at 12. And I promise you we won't go into extra time there. West Essex CCG and Herts Valley CCG will also be holding a local review of the year in September. Details of these meetings will be published on their website closer to the date. Thanks again, and let's hope that on Sunday evening we will all be as happy as we are today. It's coming home. Bye all.